this is an Abbott. This is Abbott's SVT discrimination program in a dual chamber mode. Okay. So this is dual chamber discriminators. Our discriminators act all the way up to the VF zone, from the bottom of the VT zone, not into the VF zone. Okay. And you can see that on this panel here, where the red light is. SVTs. So anything up to the VF can be classified as a supraventricular tachycardia. Okay. Yeah. Happy?
Sorry, you mean you have the SVT covering the VT and the VT2?
Yeah.
That's normal?
That's normal. All the way up to the VF zone. So we stop SVT discriminating at VF. Okay? Yeah. So that's important because if you had a young patient and you were programming a low VF zone, you might want to push the VF zone so you get SVT discriminate, right? Okay, so this is our algorithm, but we'll just inject the rhythm into it. Let's see what happens. So that rhythm there is, don't complicate it.
It's VTAC. It looks like VTAC.
It looks like VTAC. It starts suddenly. It looks different.
Yeah.
There's probably, I can't
regular,
see.
it's monophasic.
It doesn't look like there's any P waves, retrograde P waves in there. So it's VA association, yeah? Yeah, more VIC. So what does our algorithm do with this? Our algorithm will do this. Down the bottom here, it says if there are more V's than A's, it treats it, and that's it. Done. Too easy. No further. Well, the discrimination is that.
Yeah.
And it goes. It doesn't say if ventricular rate is greater than atrial rate, deliver therapy.
That's some sort of a PR logic.
Yeah. We might use that name, but yeah. More V's than A's equals VT, which is true, right?
Yeah.
Unless you're atrially undersensitive.
Okay.
So if you're atrial sensitive, you need to have good atrial sensing, right? Okay, right. More V's than A's deliver therapy. Okay, so that gets therapy. Easy. This rhythm. So we'll inject this into the
It looks like it's in AF.
So there are lots of A's and not many B's.
Yeah.
So there are more A's than B's. And if you had to describe this to an F1, do you have called F1s here? You're very, very new doctors. What do you call them?
F1.
F1s?
Yeah.
F1, they're new ones from school, straight from school, yeah. So if you had to describe this rhythm to an F1, it's irregularly irregular. Yeah. Irregularly irregular, lots of A's, not many B's. Okay? So we'll inject that into the algorithm. So we have more A's than B's. So it goes into this, so it starts up, so it's, okay, if I have more A's than B's, I'm going to look at two things. I'm going to look at what the morphology looks like. Morphology looks narrow, looks like sinus rhythm, something coming through the AV node. And then we look at interval stability, which is how irregular it is. So that looks, okay, so we have more A's than B's. It looks the same as something coming through the AV node, and it's irregularly irregular. The device says, don't treat it, hold off therapy, okay? Both have to indicate VT, okay? So it would have to look different to this, and it would have to be regular to get treatment, okay? Yeah? Which could happen. You could have more A's than B's, yeah? But it's also VT. Because if this AF patient went into VT, he's still in AF, A is more than B, the device goes, okay, A more than B, morphology looks different, that looks regular, treat it. Okay? Alright, that's how the logic works in this device. And all of this is programmable. But very, very rarely would you need to change it. Okay? You just leave it as it is, comes out of the box. So out of the box settings on our SVT discriminators will get you around about 1% inappropriate shock rate. That's pretty
good enough for
right?
everyone.
So I don't know if when you consent patients, you say to patients, well, did some patients ask, will I get an inappropriate shock? Yeah. So what do you tell them? What number do you give them? You have a 10%, 20%, 30%, huh? Don't give a number, yeah.
Just reassure the patient.
Just reassure them, yeah. Well, you can reassure them. This is low. It's low likelihood, okay? Okay, this rhythm.
Sinus
tachycardia. Explain it to the F1.
It's regular.
It's regular.
Every P has a corresponding wave.
Narrow.
Yeah.
Gradual increase in rate.
Yeah.
Yeah.
Warm up,
All these
cool
things.
down.
Gradual increase in rate, up or down.
Warm up,
So
cool
going on
down.
this here. A equals B. It looks like it's coming through the AV node. So this is it's exactly what the device does. So it uses like your logic, right, that you're using, because I'm even guiding you towards it, right? So V equals A. Looks at the morphology. Does it look the same? Yes. And it, by the way, the device constantly updates this template. So it updates the template every 3 hours. So every 3 hours, it goes, okay, I want a new morphology template. Okay? So it's constantly updating it, but sometimes these things change. The morphology says SVT. Arrhythmia onset. So what we use here is it's actually so we look for an increase in rate, small increase in rate, but also we want to see which chamber is driving the tachycardia. So it has something called chamber of onset. Okay, so the rate is going up like this here. Okay, and then it says, is it the A or is it the B that drives this? Okay. With sinus tachy, you won't get a jump in rate. Okay, you'll just gradually increase. So the device will say SVT.
We have sudden onset off.
We have sudden onset off. Or we have chamber of onset on, and in chamber of onset there is a sudden onset element. Okay.
Thank you very much.
So imagine if you had this rhythm here. Where's all the EPs? Sinus rhythm, sinus rhythm, sinus rhythm, sinus rhythm, something else, something else, something else.
And then to read P waves.
I've got the arrows on them.
Yeah, and it's in V1.
Yeah.
Like a VNRT.
AVNRT, right? This is an AVNRT, right? Yeah. What started the AVNRT?
The premature beat.
A premature atrial beat, yeah?
Yes.
PAC, right?
Yeah.
So let's go back to the algorithm.
The chamber of onset is
Correct.
the atrial chamber.
Yeah. So it goes in here. Morphology says looks like it comes through the avian node for AVNRT. Chamber of onset, the atrium drives it.
Yeah.
So it says SVT. So it holds off there. Okay. Both would have to say VT for it to deliver there. Okay. Yeah.
ICDs have come a very long way.
Nice. Our ICDs have come a very long way. Okay. This rhythm.
It's
That's VF.
VF. So what will it do? How will it go into here?
They've got more beats than
no
A.
discrimination.
Correct. It doesn't go in here because it treats it as VF and it ignores
That
it.
shifts,
Right? So
that shifts the counters.
That counters have detected it, it's fast enough, yeah, absolutely. So this is VF, doesn't get, if it's fast enough in the VF zone, we don't discriminate, okay? It would be stupid to discriminate this, so we don't. Okay? So that's how our dual chamber algorithm basically works, right? And all of this functionality here is all programmable, right? But default, out of the box, works really, really well, right? Like, you don't need to change it. You only need to change it in special circumstances. Over here, there are two things that we need to just be aware of. SVT discrimination timeout is normally off. Out of the box from the factory, it is off. But this, if you turn this on, the device will only inhibit therapy for an SVT for a programmed period of time. Okay, so this will come up in 1 minute, 2 minutes, 3 minutes, whatever. So this means that the patient is in, let's say the patient is in fast AF. So this channel here is saying it's AF, hold off therapy, hold off therapy, hold off therapy.
Couple of minutes.
2 minutes time, ignores this here and starts to treat the patient. So this is a bad idea.
Yeah.
Leave it off, okay? Don't turn it on, okay? Yeah. SVT upper limit is same as VF. You can program this lower than the VF zone, okay? So if you had a patient who had bit of AV block, and you were programming very high VF zones, let's say at 230 beats per minute, and the patient has an intermittent AV block, what's the likelihood of this patient conducted at 229 beats per minute?
145.
Yeah, you can make this number smaller, right? Because they're not going to conduct that fast, are they?
Yeah.
They're not going to conduct.
Can we go with that?
Sorry.
Can we see that?
Yeah, so this here is the maximum rate at which it will SVT discriminate. So normally you leave this same as VF.
Yes.
But if you have a patient who has a bit of AV block, like intermittent AV block, damaged AV nodal conduction, their likelihood of getting very fast, like maybe 220 beats per minute through the AV node is 0.
Yes.
So let's not bother discriminating at that rate then. Let's bring down the limit to where SVT discriminates. You know, you can do a wing back test and test that if you want to, okay? It just makes the device a bit more sensitive, a bit more specific.
Okay.
And it's the sensitivity of specificity is happening at those very fast rates where if the device gets it wrong, it's serious. Okay? Now, it's unlikely to get it wrong, but why not? You know, you're all about, doctors, you're all about reducing risk, right? Mitigating risk. Why not mitigate that additional risk, okay? Yeah? You know, I'm flying back to London tonight. You know, the pilot's fine, right? He gets the plane, he's fine. If his co-pilot's drunk, it doesn't mean that the plane's going to crash, right? But I'd rather he wasn't there. So we mitigate risk a bit, okay? Yeah? Okay. Single chamber discriminators. So when we only put one lead in,
Yeah.
now we have potentially 3 discriminators. So what rhythm is that?
That's VTAC.
Yeah, so what do we use on our device? We use morphology, we have onset, we have stability, but we don't use them. They are off or passive, okay? So our default out-of-the-box settings, which work, don't change them unless you have a particular reason to change them, uses morphology alone as the discriminator, okay? That's it. Don't use interval stability, don't use a chamber of onset, don't use southern onset, okay?
Why is that?
Why? Because it works better with morphology alone, okay?
We've got to the point where the morphology,
Correct.
the templates can actually...
Yes, it's better. So if you consider southern onset sinus tachycardia, correct? Differentiates between VT and sinus tach, okay?
AVRT comes in once,
Yeah, VT.
AVRT comes in once,
Correct.
VT comes in
Yeah.
once.
But also think about your ICD patients. You know, your primary prevention ICD patients. What rate are you programming their VT zones at? 180?
Most probably, it's a normal case.
180. 180, right? Primary prevention. How many of your ICD patients can get sinus tachy at 180 beats per minute?
If it's young, a lot.
Sinus tach? Exercise sinus tach? To 180?
If it's a young man.
Yeah, maybe if it's a young man, but that's not your standard ICD patient, right?
No.
No, that's your prime prevention patients have got depressed ejection fractions, they're on beta blockers, their chance of getting to 180 in sinus tachycardia is 0. Or pretty damn close to 0, okay? Yeah. So therefore, sudden onset in that population is pointless because they don't have sinus tachy. So it's only going to get it wrong. Okay? Because you can imagine if you had VT. Right, so patients at 60 beats a minute, and then they go into VT at 179 beats per minute. And their zone is programmed at 180, and they're at 179, 179, 179, and then they just go across into the VT zone. What's sudden onset going to say?
Nothing.
It's going to say hold off therapy. Because it would measure between 180 and 179, okay? And sometimes you see that. So these are not particularly interval stability and sudden onset. They're not particularly helpful. So we recommend morphology on.
And the morphology
Default settings.
and the Apple devices, do they use the near field and the far field?
You can program it. It uses the near field to align the signals.
That's timing.
Yeah, but the morphology is created from the far field signal. Okay, but there is an alignment with the sense signal, with the R-wave, with the V-sense amplifier. Yeah.
So do you use the near field to make sure there is no
To make sure that we're picking up the start of the signal.
Okay, then we use the far field for the shape.
Correct. Yeah. Correct. Yeah. So what would single chamber discriminators say here? Well, it's sudden. So let's say if we look at all 3. So sudden says VT, irregular says VT, morphologically different VT. Okay, that's too easy, right?
Yeah.
Okay. So all say VT, but we're just using morphology.
So what if the patient had SVT
With aberrancy.
and a very right bundle branch block? Developed right bundle branch
You'll get shocked.
cardiac.
Then,
so how does the
yeah,
device-
that-
For better or for worse,
Yeah,
you'll
that
get
does, that sometimes you will see that happen. You can see that happen. Not particularly common actually, and I think it's not particularly common because they've got diseased conduction system. So when you program them at 180,
Oh, but if it's a single chamber ICD,
Yeah,
so
but
for a private prevention, probably not.
yeah. So but if they're right bundling, then they have some kind of conduction system disease. So the likelihood of conducting up at 190 beats per minute
So the rate
is low. Yeah, and that's why we keep rates up. That's another reason to keep rates up. Those kind of difficult rhythms that are hard for the computer to work out aren't even looked at.
Okay.
Yeah, does that make sense? I agree, but if it went at 190 and it was very aberrant, the morphology could call it VT. Yes, it could.
What the morphology actually does is only compares what it sees now to what
What it has scored.
science.
Yes,
It has only one template to correct.
correct. Yeah. Yeah. But you're right. So in that situation, you saw a patient who got inappropriate therapy for aberrantly conducted AF at a very, very fast rate. You know, what do you do with that patient? You give them drugs, right?
Medication.
You give them medication, right? You give medication, and if they're, and then you could alter the discriminator a little bit.
Excuse me, sir.
Yes.
How often is the template update?
Every 3 hours.
You say that I didn't believe her.
She can read the slide. She can read the slide. That's there is there. Yeah.
3 hours.
Every 3 hours. This is the way she knows what she's talking about. All right. This one here. How would this be discriminated? So what would morphology say? This is the DT side. Looks the same. So we're done. Yeah.
It's irregular.
It's irregular. So intervals. We'll call it AF. And what would sudden onset do though? Sudden onset might call this VT. Yeah. If you're paroxysmal AF, you're normal, then you go fast. So this could call it VT, right? There's no reason why we don't like it. It's too specific. This is like a broad spectrum antibiotic. These are very, very specific, right, to certain rhythms. Interval stability only differentiates between AF and VT. Sudden onset only between sinus tachy and VT. This, everything. It all. Okay. You can see morphology would get that right as well. Yeah, morphology would get that right. Would morphology get this right as well? It'd get AVNRT right as well. Okay? And think about if we used all. Sometimes we think more is better. So let me put the other two on as well.
Okay.
Then put the other two on. Let's run through the algorithm. Morphology says SVT.
Yes.
Interval stability would diagnose
It's very stable.
VT. Uh-oh. Sudden onset,
Yes.
VT.
So it's morphology.
Yeah. So we would
The device would
deliver therapy.
As long as it's good enough, let's keep it
We
morphology.
always use morphology. It's good enough. Honest.
And the new devices.
But the
I
new
believe
one.
you. I believe you.
Honestly.
The older devices you need.
Okay. All right. So that's a run through of our SVT discrimination. Right? Happy?
Yeah.
Any
Very
questions on that? Good. Quick case report. This is so I think case report, right? This is I have to remember what's going on. I remember. Okay. So here's the device settings. So I was called to see this patient in a hospital ward. He'd been admitted. The device is set VVI 40, VF zone at 240 beats per minute. This is a high VF zone, and a VT zone at 187. So why do we program high zones? What's the reasoning behind programming so high? Yeah, for primary prevention, but what for reason? Why go high? Why not just bring them? So we don't deliver inappropriate therapy, right?
Yes.
So for reduction of inappropriate therapy, and also to reduce unnecessary therapy. Okay, i.e. treat VTs that don't need treating because they stop, right? That kind of stuff. Okay? So this patient's got lots of episodes though. Okay. So let's have a look at, and he's pacing 26% of the time. This is it, right? Okay, so at 40 beats per minute, he's pacing 1/3 of the time, nearly 1/5, right? So he's got
You said 40
bradycardia,
beats per
right?
minute. Where did you see that? This is
He's got AV block-ish. He's basically got AF with a bit of AV block, right? So if you're pacing for nearly 1/3 of the time at 40 beats per minute,
At the same time, he has high rate.
yeah, and by the way, he was SVT discriminated all the way up to 240 beats per minute, right? He's in AF. His AV node is being hit at 300 beats per minute and it's not conducting. So he's never going to pass through his AV node. So this guy probably doesn't need SVT discriminating all the way to 240, right? This is the type of patient where you might want to reprogram that a little bit, okay?
Okay, let's go back there. I lost.
Yep,
I
sorry.
lost.
He's got AF,
Yes.
he's got a lot of pacing, 26% pacing,
Yes.
so he's got AV block, right?
Yes.
Probably.
Makes sense.
So do we need to be, he's SVT discriminating all the way from here to here. Do we
No.
need that?
No.
We don't need that.
No.
And we could even consider, because we know this guy is in an SVT the whole time, but it's not conducted, we could also say, that's quite high really, isn't it?
Yes.
Because actually you could drop that and not going to increase his risk of inappropriate therapy. Because we're testing his AV node all the
You
time.
mean we could drop his VF mode to
We could even
187?
drop his VF zone, right? This is quite aggressive programming.
He's not
This
going to
is-
get therapy.
This is not, he might not get therapy yet. This is quite aggressive programming. Okay, so here is 3 of his episodes. They all occurred quite close to each other. Well, they're a little bit separated, but let's just zoom in on what's going on. And then So this is the start of this is episode. Any thoughts there? Single chamber, right?
Yeah.
Any thoughts?
Looks like VCAF.
Is it paste bead and then a PVC? And the PVC stored in the
Okay.
tag?
And have a look what the device is doing. It's going 1 in the VT, 2 in the VT, 1 in the VF, 1 in the VF, 1 in the VT, 1 in the VT, 1 in the VF, 1. So we have cross-zone counting, okay?
Yes.
Which means it's going to delay time to detection because one's going in one bin, one's going in another bin, one's going in this bin, one goes. So it takes time to get. It takes longer to get there, right? And this is quite an aggressive rhythm, right? Yeah.
Yeah.
It's got 250.
It's fast, yeah. So we've got about 40, 250 beats a minute, right?
So here's the lane therapy.
And then what about this? What about this episode here?
That's V. That looks like VF.
That's VF. Yeah, but that is VF. No doubt, right?
Yeah.
Anything else about it? It's just VF, right? Okay. And then another episode down the bottom. What do you reckon? This is all VT, right? Remember, this guy's his AV node is being challenged all the time by his AF, and he doesn't go fast. So if he goes fast,
It's something from inside the ventricle.
it's a ventricle, right? So
So why is he so aggressively programmed?
that's the question. I don't know. I didn't think so much maybe about the programming. Okay. Anything else? Anybody want to make any changes? So we might want to make like
You want to switch off SVT?
yeah, maybe or lower the VF. Yeah. So well, it's about this. It's about how its VT starts or its VF starts. Its VF starts every single time with a ventricular pacing pulse. Every single time, every episode this man had was initiated by V pacing. Now that could be statistical fluke, right? Because he does pace 26% of the time, but every episode, and it's polymorphic and horrible, right? So normally your primary prevention patients don't have polymorphic VT or VF, do they? They have monomorphic VT. They go to monomorphic VT and vice versa. To go straight into VF like this is reasonably unusual. Okay, so this is V-pace induced arrhythmias. Okay,
Was he treated? Was he shocked?
I'll show you in a minute. Well, step one though is picking up that we are probably pro-arrhythmically pacing.
Yeah.
So we might need to turn pacing off, although he's got AV block. But we might want to see how AV blocky his AV block is. Okay. So in these situations here, when you're seeing this here, this is complicated by AV block. But if there is an AV block, sometimes we think, oh, let's lower the pacing rate. That doesn't make it very. That usually doesn't work. You sometimes just have to turn pacing off. Okay.
Facing off.
Turn the pacemaker off.
He goes low.
Yeah, he does. But let's say we haven't got AV block here. He's difficult to manage because he has got AV block.
So does it change where he's pacing from?
We could do that. You could put a biventricular device into him. He's 26% RV pacing. He's got a diseased ventricle. He's a candidate for CRT, right? And then that might help him, right? That will probably have helped him. Anyway, so first step is though to be able to, when you see any episode, look and see did pacing start it. It's not uncommon, and it's called pacing. It's called PITS, P-I-T-S, pacing induced tachycardias. It's really not common. Not uncommon. Like it's quite common. Okay? And the fix is normally just stop pacing, and if they don't need pacing, turn it off.
Just the pacings?
Just
not
pacemaker.
the timing of the pacing.
Yeah, just turn
It's not
pacemaker.
the pacing on my bottom, but the
Just turn it off, yeah.
Just the pacing.
Just turn pacing totally off. This is what you should consider. Not say you should do it in every patient, but you should consider turning it off. Fully off. So your primary prevention patient you put a device into, right? Skin and heart disease, low ejection fraction, science PR interval of 170. Would you put a pacemaker into it? Would you implant a dual chamber pacemaker? No. Because he hasn't got bradycardia or symptoms. So it's okay to turn the pacemaker off,
I
right?
want him to be bradycardia.
Yeah. You want to do bradycardia, but you don't want him to pace, right? You might want to, you could AAI pace potentially. If it's science driven, right? You could AAI pace, that's safe. Sure.
Does
So-
changing the amplitude or the duration have any effect?
We have two problems.
Dropping the rate has been shown to in hits in patient-induced tachycardias in single chamber devices not to help. You might be able to do it in dual chamber, put the rate up, and you might be able to help now. So it's just pacing at a vulnerable period.
We have two problems, if I can sum it up.
Yeah,
One, every time we pace, he goes into VTAC or VF. Two,
yeah,
he detects his VF
badly.
badly.
Yeah,
So-
look here, he's in VT and he's not even detecting. It's saying VS, VS, VS. This is sinus rhythm to the device.
So if you bring zones down,
Yes,
he'll get more treatment,
and you will get more treatment.
but the treatment is due to what we are doing during
Correct.
pacing.
Yeah,
So I think what you said is, if he has to be paced,
yeah. We might want to think about IV.
okay, so
Device.
this is a different, this is an indication, just simply, okay, if we move the lead, if we cannot, we're in a third world country,
Yeah.
to upgrade is not
No.
that easy.
Yeah, yeah.
If we move the lead from where it is,
Yeah.
it may be different. We're maybe pacing in a scar.
I don't know. That study hasn't been done. Nobody's done that.
You know the rationale or?
Yeah. You get the lead out of SCAR. Yeah.
Yes, I mean
Possibly.
maybe.
Possibly, but maybe I don't know. I don't know. Couldn't
Should
tell
we
you.
consider medical treatment for somebody like that? I can't switch up
I
pacing.
mean, remember, he's pacing 26% of the time, right?
But that's
so he
a
does
lot.
have R waves, So,
Yeah.
but he probably needs 5 pacing, right? Anyway, let's go on and look at. He's a difficult patient to manage. Point I'm doing with this is we're pacing him into VF, no doubt,
Okay,
right? No doubt, so we need to fix that.
okay.
And then when he goes into VF, let's have a look. When he goes into VF, well, here's the patient in VF, right? This is the patient in VF or polymorphic VT. It's horrible, whatever it is, going at very fast rates, right?
Yes, yeah.
250 over 250 beats a minute. Patient gets shocked and he comes out of his VF. Yeah. Yeah, he's out of VF.
No.
No, it's not a VF.
Sorry, he says V sensing, not
This-
VF.
This here. So here.
Why
V
did he?
sense.
Why did he shock? He's saying V sense, not VF.
This is the reconfirmation.
Okay.
Yeah.
It's still within the VF zone.
Okay.
So it shocks him and it changes the rhythm a little bit.
Okay.
And then a couple of minutes later,
Comes back.
we see this. And we're ATPing it. What rhythm do you think this is?
That's VF.
It's VF, right?
It's
It's
there.
a slowly detected VF, right?
And then ATP during charge.
And then ATP, we're delivering ATP for VF.
No.
Not going to work, right? So this is ATP for VF. Although sometimes when they're in VF, you expect it to look very fuzzy, right? Sometimes it can look organised. And you'll see that, right, if you do AF ablations, one side of the atrium's in AF, the other side's kind of fluttering, right?
Yeah.
And you can probably see, you can see the same at VF, okay? So this man is in VF, the device, and look, some of these intervals are in the sinus zone. So we shocked this rhythm, good, although we put him into it, so that's not right. We shocked him, we slowed it fell out of the VF zone and the VT zone, and then it moved back up again.
We're doing horrible.
We're doing a bad job here. Okay? And move past that, What's this? Oh, there's the initiation. So here's the shock. 1, 2, 3, 4, 5 sinus rhythm. Not sinus, it's VF.
It's VF all the way.
It's VF all the way, right? So what do we call sinus rhythm? This is crazy, right?
This is apples.
Because it's
Hey.
slower.
Just lower than 100, anything lower than 187 is sinus rhythm, right?
Yeah.
And this isn't a man who has AV block.
I'm just playing with you.
No. So when you're programming zones, right, 187, a VT zone, the other thing to consider is that anything lower than that is sinus rhythm
Yes.
after shocks. So when you shock somebody and their VF slows, or the detected rate of it slows, if you keep that zone too high, inappropriately, this is an inappropriately too high thing, right? This can happen.
I'm sorry, sir, but do you mean that after he shocks,
Yeah.
he doesn't use the morphology discriminator? He only
No.
counts.
Doesn't use anything.
He only
we're,
counts.
once we're detected VF or VT, we're treating it,
Oh, so
which is safe. Wait, that's
we're
safe.
treating it only
on rate.
on rate.
Yeah.
Thank you very much.
Yeah. So so here's the shock. At this point here, anything less than 187 beats per minute
We're not
is
going to
sinus
detect.
rhythm.
We're
Yeah.
not going to detect.
If it's more than 187, the device continues with the next VF
Redetection.
shock, the next VF shock, the next VF shock.
And they're all
Non-committed.
non-committed.
Every shock in the lab device is non-committed. Okay.
Every shock is non-committed.
Yeah.
Not only the first shock.
Yeah. All of our shocks are non-committed
Okay.
and
so
synchronized.
all are synchronized.
All are synchronized. All are non-committed.
What if it's VF? How is it going to synchronize it with VF?
This is VF. Synchronized with VF. Synchronizing the R wave. Just find an R wave. Shock it.
Okay. That's more safe.
Yeah. Yeah.
So it's
Okay.
not like the ECG, it's an intracardiac.
Correct.
Yes,
Yeah,
yes,
small.
yes, yes,
Fine.
yes.
Okay. And then this is 9 minutes later.
He's still
9
alive.
minutes later.
He's still alive.
Well, this is VF.
I think he's alive due to the ATP.
This is now 9 minutes after his after that previous episode. Okay. So we did shock, this rhythm, sinus rhythm. Job's done. Device is working perfectly.
And the man died.
9 minutes later, we have this rhythm being stored in the device.
Recent.
It's VF.
Yes, recent.
It's just VF.
Only noise.
It's VF. He was on the floor in his house
VFing.
in VF.
For 9 minutes?
9 minutes.
The guy had ATPs, you know.
He was being resuscitated
Okay.
by his wife
Yeah.
and called an ambulance.
Yes.
The ambulance turned up and shocked him.
Did this man make it?
Yeah. Amazing. He was he was a bit neurologically damaged. Like quite neurologically damaged, but he was okay.
Well, I think that
He's
this is it's our fault.
They didn't sue the,
It's not your fault.
they
Yeah,
didn't
it's-
sue
it's
the
a physician's
company. They didn't sue the company.
No,
It's not
you'll
the
see the
company.
doctor. You'll
He
see the
sued the
doctor.
hospital.
You'll see the doctor.
He sued the hospital.
No, he could sue the hospital
Yes,
if he
he
knew.
could.
Yes,
But
he
he was
could.
neurologically damaged, so he didn't know
Yeah.
what to do, right?
Good for everybody.
Absolutely.
Good for everybody.
No, it's true. He could have. He could
That's
have.
very bad
Absolutely.
PR. That's very bad PR.
Yeah,
Both
this-
doctor and
yeah.
abbot.
If you like the story here, so there's a number of things going wrong here, right?
It's our fault. This is
Correct.
This is our fault.
It's our fault. So
It's not the machine's fault.
when we go high with zones, we just should not just go blanket high with everybody. Blanket high, blanket. We kind of should just look at the individual, right?
Those zones are not out of the box zones.
No,
So somebody did play with those
correct.
zones.
They did. Someone
Yes.
played with those zones very significantly.
That's not the machine's fault.
No, that is not the machine's fault. The machine is a robot and it does what it's told.
Exactly. And
It
those zones
it
are
has no
very far
empathy,
away
no
from the
thoughts,
default
it just
setting.
does what it's told to do.
That's very far away from the default setting.
Yes. Yes.
Did the patient before get inappropriate shock? That's
No.
why they had
No.
to.
She's thinking right. Maybe
Yeah,
that's what
no.
put the doctor.
The patient did not get any inappropriate shock. The patient had no signs of ever getting inappropriate shock.
But I have this notion.
Yeah.
None of us are very, very highly experienced. Maybe we're not like Professor Rodney, Professor Berman. So I think stay with the default.
I totally agree with you.
Yeah.
Except
Stay
if you
with the
have,
default.
Yes.
On that Abbott device, stay with the default. It works really well.
If you want to change
If you want to change it, you need to have really
back to
you
somebody.
need to have good reason to change it, right?
Get back to
Absolutely.
somebody.
Because if you do, this is the stuff that can happen. And this was done by quite an experienced centre, right? This is quite a big hospital that did this.
Okay.
And I don't think they learned very well from it either.
You're not going to go home.
No. Oh yeah. No.
Okay.
No. Anyway, okay. So number of problems here. We paste him into VF.
Yeah.
Right. Maybe there's not so much we could have done about that or predicted, but we did paste this man into VF 3 times. So his shocks didn't work. Right. That didn't work. Okay. And there were other shocks that didn't work. So his shock, his defibrillation threshold is high.
That's a
It might be
different
high
problem.
because he's been in VF for quite a while. So as we prolong VF, DFT go up and up and up and up.
Sorry, that's the third problem. One,
Yeah,
we
yeah.
put him into VF. Two, we could not
didn't
detect
detect
it.
properly.
When we did detect it and give
The shock
shock,
did not work. Yeah.
this man's very,
He's very unlucky.
That's
Yeah,
very
very unlucky.
That's very
Sometimes
unlucky.
it happens.
And sometimes
Sometimes
it
it
happens.
happens.
We call it in the UK the Swiss cheese effect. So when all the holes of the cheese line up,
That's-
get a problem, right? You can go all the way through the hole, right?
Yeah.
Normally something blocks it. I don't
Exactly.
think it's cheese, yeah?
Yeah.
But all the way through. So he has a Swiss cheese effect straight through, right? No problem. Okay? So the detection we talked about, pacing we talked about. So we can now think about fixing his defibrillation threshold. And actually, he's got a high defibrillation threshold, this guy. Okay? So how can we fix his defibrillation threshold? Is there a way of changing this man's defibrillation threshold?
Maybe check the vectors.
Check the vectors. Let's have a look. Okay. So his high voltage lead impedance was 77 ohms. Right. Single coil, it's normal. It's in normal range. Okay. But this produced a shock waveform duration. So when we do a shock, we have two phases. Yes, biphases. A shock. First phase, which is current going this way. Second phase, going this way. Okay. Coming from coil counterpoint, right? And it was 8.5 milliseconds first phase, 8.5 milliseconds second phase. We think that the optimal shock waveform is probably about 4.5. So he has a long waveform, which might make it ineffective. Can't prove that on this patient because we didn't DFT him, but we should consider some of the evidence base around shock waveforms.
Sorry,
Okay?
sir. 8.4 is not out of the box.
8.4 is related to the impedance. So when you deliver 36 joules, okay, you deliver 36 joules over a through the shock waveform, right?
Yes.
So if the impedance is high,
Take more
it
time.
takes longer to get the current out, right? So the waveform gets longer, it stretches, right?
That makes a lot of sense. Thank you.
So it
But
stretches the waveform, right?
Yes.
If the impedance is low,
it'll be faster.
be faster.
Yeah.
So
But-
the only way we can change this is to make that lower.
But that's still normal.
Yeah, that's normal. Okay? But there are other programming considerations that you can change this number, right, without changing the impedance. Because you can't change impedance because that's physics, right?
Yes.
Unless you put more metal into the patient, right?
But change,
Well, it must
but
put
change
more metal.
where the lead is.
Yeah, that's not going to change the shock impedance. It might change the effectiveness, but it won't change shock impedance.
I'm sorry, sir, but if I have the tip of my lead in a scar,
Yeah,
you have a high impedance.
no,
Why not, sir? It's fibrous tissue.
no. Shock impedance. It's about the. No. If you're in fibrous tissue that is calcified, so calcification happens at the tip and the ring, then your impedance will go up. If you're just on dead tissue, your impedance will be normal. If I got a pacemaker lead,
Place in shock.
yeah, both. If I got a pacemaker lead and poked it into your eyeball, right?
Yes.
Like pinned you down, pushed the pacemaker lead in your eyeball,
You hit
and left
it
it
a
there
lot.
for 5 minutes, and then measured the resistance, it would be normal.
It's all tissue.
Yeah.
It's all
just
electrolytes.
fluid, electrolytes, yeah. It would be normal.
You mean to say if I do have high impedance, it's not where I have the lead implanted, it's something that has to do with
Broken.
the lead itself,
The lead is either broken or it's in calcified tissue.
which is very, very rare.
Yeah. Those are the two cases. Or it's in air.
Yeah.
So actually, I do move the lead only to have better sensitivity.
Better sensitivity, better thresholds. That's it. Okay. So let's look at the shock waveform stuff. We'll go past that. Shock efficacy, go past this. Okay. So, to tune a defibrillator waveform, to make a defibrillator waveform more effective, we can do a number of different things, right? We can change how long it is, how long the waveform is. We can change the direction of the current. We can move the RV. Let's say we're not moving leads anymore, right? So we're not moving the lead. This is implanted in this patient. We're not going in again, right? So now we can play with a number of things. Go back one stage, and they're all in here. So we can change the vector, direction of the current flow. We can change the polarity, and we can change the duration of the waveform. Those are the three things you can do. That's all you can do, right?
The vector, do you have a vector that statistically you say is the best vector? Or it does differ from patient? It does differ from patient to patient.
So all the data on shock waveforms, right, was done mostly, almost all of it was done with 3 electrode systems. So RV coil, SVC, and a CAN.
Yes.
Okay. And what that said is that apical placement of the RV lead is better. Okay. Put the lead at the apex.
The
It's better.
vector here is from
RV coil, RV coil to
both.
SVC to CAN and then back, okay? So putting the lead at the apex give you lower DFTs, right?
That was a question we always had on our exams and we
Yeah.
never got it right.
So now, do anyone put dual coil leads in anymore? You all put single coil leads in? Mostly?
Cheaper,
Yeah, single coils?
easier to extract.
Easy to extract, right? So we go with the same theory that it'll be better DFT if you put it at the apex.
Yeah.
But that data was done on dual coils, so we don't really know if that's true or false, right?
Yeah.
With the single coils. So there's a study going on at the moment, recruiting at the moment, somewhere in the US, looking at putting single coil leads in a settled position.
Here the vector is going to be from the coil to the cam.
Coil to CAN, yeah. So if you've got an RV coil at the apex, right, it's quite anterior, right?
Yes.
And a CAN up here, right? That's anterior, that's anterior.
Yes.
Left ventricle is posterior.
Yes.
That doesn't
Oh.
make any sense.
Yes.
That's not biologically plausible anymore,
That's a
right?
very nice diagrammatic.
Right? So why don't we put the coil posterior
Okay.
on the septum, right?
Yes.
So because when you deliver a shot, you can measure the current density around that coil, and it kind of is a